Okay, hello everyone. We're going to be going over Beauchamp and Childress today, and there's a lot of good stuff here for people who are not even interested in bioethics more broadly, even if you're going into nursing or some kind of more applied field. There is a very nice way to get hold on what we mean by autonomy in bioethics and how it can relate to how you should make decisions as a medical professional. So without further ado, let's start talking about this. This is one of the more important works in bioethics, and it's trying to answer what you need to know to make the uh, to make an informed decision and what informed consent is. And we'll be talking about patient autonomy here and not doctor autonomy, although we will get to doctor autonomy in a later lecture. So Beauchamp and Childress point out that medicine has been traditionally concerned with the well being of patients and not necessarily their autonomy. And this turn to autonomy has been kind of a shift in the last century, mostly. And they focus on autonomous choice rather than on general capacities, which is why they have a pretty unique view of autonomy. A lot of other views focuses on capacities, and we'll go by them in brief. But capacities obviously have importance for Beauchamp and Childress' view, and we'll talk about that as well. And this idea that the patients don't really know how to make medical decisions is backed up by this other medical view of this other medical principle of beneficence. So autonomy is going to enforce the patient's freedom to choose, and beneficence is going to be what is actually good for the patient. And you can see the tension here, that there's some kind of tension between what the patient wants to do and what the patient should do if they wanted to maximize their health. And again, medical ethics takes health to be a primary concern of the institutions such as hospitals, clinics, and that's why they think that in some cases they can override autonomy. And to kind of get a grip on what autonomy etymologically means, so autos is self and nomos is rule, so it just literally means self-rule. So back to this historical disregard for autonomy, there was a lot of paternalistic doctors who would even withheld truths from patients that they were treating because they thought it might harm them. It might harm them because they might do something, or it might harm them uh, mentally from knowing something. So historically, getting patients' consent was just mostly a one. It was on the first hand, it would facilitate treatment. If the patient agreed, they probably wouldn't fight you as you administered the cure. And then another one is that there was a kind of reputational advantage to doctors who got consent. People didn't tend to want to go to doctors who didn't get consent. And you might actually feel that a doctor who does get consent acts a bit more virtuously. So mostly a marketing ploy in the early 20th century. So as I just said, autonomy can be opposed to well-being, and you can see how these values of beneficence and respect for autonomy can be in tension. So what is best for someone may be contrary to how they want to live their life. So people make mistakes, and medical well-being might be opposed to certain ways or choices of living. So it's worthy to talk about what Beauchamp and Children are not doing. So they specifically reject a Frankfurt-inspired account of autonomy in the article. So the Frankfurt account of autonomy is something like there's in order to act autonomously, you need to have no gap between first order and second order desires. What is a first order and a second order desire? So a first order desire is something like you see a donut and you want the donut. Second order desire is something like I have fitness goals and that means not eating the donut. And you can see how these are in tension. On the one hand, my first order desire wants me to eat the donut. On the second hand, My second order desire wants me to not eat the donut because I'm trying to be healthy, trying to be fit. So when there is no tension between these two desires, when I see a donut and I think, no, I don't want to actually eat it, but then reflectively at the second order, I think that's actually what I want to be doing. Uh, that's when I'm acting autonomously. And when there's a tension is when I'm not acting autonomously. So if I'm eating a donut, but I'm thinking to myself the entire time, I really shouldn't be eating this donut. That is when you're not acting autonomously because your first order desire to consume the donut is in conflict with your long term second order reflective desire of being healthy. So the gap is to show, so the gap uh, is that second order desire can't directly determine the first order desire. This would be, this is kind of an objection to the Frankfurt view, which is to say that if an alcoholic has a first order desire to drink, they see the drink they want to drink, and then they think, uh, drinking is really what I want to do with my life, then this would be something that seems autonomous under the Frankfurt view, but something that strikes us as a bit odd. We feel that the alcoholic is making some kind of wrong choice. He's not really acting in his best interest, or he's not acting uh, in some way that we find would be required to be autonomous. So he's drinking all day. We think that that's probably not something an autonomous person would do. So there's a supposed tension here. Um, and that's why the Frankfurt view is not exactly appealing. There's stuff that we could do to make it a bit more appealing. But in essence, there's tons of examples where we could show heroin addicts, for instance. It would seem that their first order desire might be causing their second order desire. So they might be taking the heroin, and then that desire might cause the second order desire to consume more heroin. So if they aren't independent like that, then it seems like there's a kind of problem with the view in that we don't think it should be the case that you're compelled to do something because it's really addictive, and it shouldn't make you act autonomously. If I take a drug and then suddenly I change my mind about what I want to do in life, I just want to be a drug addict. On their view, I'm acting autonomously. On most common uh, lay understanding of autonomy, this is not something that's acting autonomously. So people try to build out this view by, instead of having second order desires, they use something like values, like that your desires are in accordance with your values. We won't talk about that too much, but let me know if you want to hear more about that. I can direct you to some papers. So one misunderstanding about consent, informed consent, would be that falsehoods undermine the validity of giving an informed consent by a patient. This is not strictly true, although there's cases of this that we could point to that is clearly true. So the kinds of scenarios that may or may not undermine consent would seem like lies would fall under that, where you're lying about some relevant piece of information and some kind of like falsehood about the treatment that you weren't aware of. That's going to be something that is going to invalidate informed consent. If you're deceiving people about the nature of the treatment, that's obviously another one. You might, withhold the truth about something deliberately, or not really reveal the true nature of something. Or you might, another one would be coercion. So the medical doctor might say, if you're not going to get this treatment, I'm not going to be your doctor anymore. That would be a way to coerce the patient, although there are some cases of this that's more permissible, but just merely saying that if the doctor takes offense at the patient not wanting the treatment they recommend and says that they won't be the doctor, that is a clear form of coercion and not respecting the patient's autonomy because it's giving undue inducement here. And then lastly, some kind of negligence. It doesn't have to be, it's obviously not intentional, but you could just fail to disclose through laziness or anything else. So I'm not going to read all this, but there's a lot of information needed for informed consent, and this is not exhaustive, so we're not going to go into it, but there's tons and tons of stuff on what kinds of things are needed for informed consent. Um, Doctor's history doing the treatments, drug effects, risks, benefits, uh, and these are all can go into way more detail uh, or not, depending on what you believe about informed consent. But we're going to get past that so we can talk more substantively about the values and principles. Um, so Beauchamp and Childress claim that there is not uh, enough for there to be an identification of first and second order desires because the second order desire could be manipulated. This is exactly what I was talking about. So the mentally ill may offer second order endorsements that are not autonomous. So if you're depressed, you might think that staying in on Saturday and Sunday to watch TV and eat ice cream is like what you want to be doing with life. But this first order desire to do that, to stay away from people, is causing this apparent congruence between your first and second order desires. And that seems a bit funky to us, right? Maybe you don't. That would be a nice thing to make a discussion post about. So what do Beauchamp and Childress actually think about autonomy? Autonomous action for them is something to be understood in terms of one, it has to be intentional. So this is not, this is just a binary. Did you intend to consent to this? And two, it's going to be with understanding, and we'll get into that more substantively later, and then without controlling influences. So 2 and 3 are kind of more scalar, that is to say, it's not binary like the first one. The first one, it's either a yes or no. 2 and 3 are like, of what degree? And for Beauchamp and Childress, that just has to be a substantial degree of understanding. There just doesn't have to be, obviously, a full understanding of medical procedures to actually consent to them. Also, you could be influenced a little bit by, say, your family members or something, and that won't undo the informed consent. So there's tons of problems of autonomy because the patients depend on the doctor and the medical practitioners for their medical authority. So this is where the coercion stuff gets to be a bit funky because on one hand, patients have to defer to expert judgments in a lot of cases. But on the other hand, the doctor doesn't have the substantive values of the patient, doesn't feel them as the patient does. So we have this kind of like tension between this autonomy and submission to authority. And it's only compatible if individuals autonomously choose to accept a doctor's wishes, if they want to accept the doctor's judgment that you should get a blood transfusion, if you're a Jehovah's Witness who they don't believe, if you don't know, in blood transfusions. So there's been cases where doctors have overridden this desire on patients' behalf, and there's cases where they've honored it and the patients have died. So this kind of tension only arises, though, when the authority has not been properly delegated or accepted. So if you delegate, the doctor is going to say, probably get the blood transfusion. If you don't, then there's this tension of the authority of the doctor and the authority of the patient, and not clear how or if it can be resolved. So in the background here of respect for autonomy is that the philosopher Kant, and we'll just talk briefly about Kant, but in the background here, he's all over, if you know Kant at all. So rational agents can determine, so the respect for autonomy flows from the unconditional value of rational agents who can determine and freely act on the basis of the moral law. And to violate that autonomy was to treat them merely as a means, not as an end in themselves. So this is to say not that we respect respect people's autonomies because it gets us nice stuff, like it gives us to be a cooperative society, or it gets us to be thought that we are a nice person. It's just a good in itself. And that's because people are an end in themselves. And to treat people as a means to an end is not something that you can do. It's something that does not respect their dignity as a person. And one of the quotes that comes out of Kant is that you should act in such a way that you always treat humanity, whether you're a person or in the person of another. So you have to respect yourself, never simply as a means, but always at the same time as an end. So you can't use people for your own gain. You have to treat them as ends in themselves, as people who have goals, and you have to treat those goals with dignity. Doesn't mean you have to let them do whatever they want. They might be lacking autonomy in certain areas, but respecting their choice requires you to take that into consideration in a substantial degree, even as much as you would with your own self. And a lot of people build rights of privacy out of this kind of view of autonomy. And in healthcare, this means like disclosing info so you can make a rational, informed choice. And so you can have voluntary action, and this is going to foster, adequate decision making with enough information. So Beauchamp and Childress say that autonomy has a prima facie nature in medicine. What does that mean? It means something like on the surface, and this is going to mean something like autonomy isn't the only consideration, the only principle we're concerned about. There's going to be beneficence, we already talked about it. There's going to be other competing principles and values, but at maybe a very poor way to put it is that autonomy is quite possibly the most important value or principle to make decisions with in medical ethics. But there are a couple of cases where there's clearly overriding concerns in cases of autonomy. So the first one is like threats to public health, contagions if you're not getting vaccinated, these things that infringe on other people's autonomy are obvious ones where you actually don't have the autonomy to act because it's not respecting other people's dignity. There's potential harms to innocent others. So there's cases where people have been talking to their psychologists and talked about wanting to harm someone and them not disclosing it to the person that they were talking about harming. And in that case, the person was killed. And since the psychologist did nothing about it, we now have rules about when you can breach doctor-patient confidentiality. And it's mostly when there's reasonable suspicion that someone will be harmed if you don't report the patient. And then obviously, you saw this in COVID, scarce resources, ventilators, etc. So something that comes out of this is that we might wonder when deception is permissible. So it might be permissible if it bestows major benefits to the patients. So there's a couple cases. We won't go into it now, but we'll get back to it in later classes. A couple cases where doctors have worried that disclosing information might lead to erratic behavior on the part of the patient, and there's been the concern that perhaps not disclosing the information would be better for the patient, even though autonomy might demand that we disclose. Maybe something that so we'll get to a couple of the critics of respect for autonomy. Some people should say that people don't actually want autonomy. They more prefer to defer and to not have the freedom to choose. So the way Beauchamp and Childress respond to this is that you don't have to choose. You can choose to not choose. That's seemingly not intention. Maybe this is something to also do a discussion post on, is if you can autonomously choose to not choose something. I think you can, but if you don't, that'd be nice to hear. So basically, your rights don't imply that you must act. It just means that you may. So it's not that you have a right to choose something. It doesn't mean that you must choose something, right? So this is to show that the critics aren't actually in tension with Beauchamp and Childress. Their account can accommodate it in a relevant way, such that people who don't really care about autonomy don't have to suffer. Um, I think there's some maybe second order effects that Beauchamp and Childress don't really consider, which is that if you go to a doctor's office and you're having a procedure, you're kind of inundated with a lot of information and expected to know whether or not you want to go through with the procedure. Whereas um, the doctor tries to not impose any substantive judgments onto you, and that can be burdensome in the sense that the doctor doesn't seem to be edging you towards any one treatment unless you ask them. And that kind of puts a burden on patients, at least, to take in the information and to assess what is best for them. So there's concern about teaching hospitals. So teaching hospitals are hospitals where a lot of medical students actually perform procedures in the clinic or the hospital. And a lot of times, so presumed consent is the idea that if you show up to a teaching hospital, you're consenting to medical students doing the procedure. So this is an interesting one because you might get less good care if you go to a teaching hospital. And it especially seems weird if you don't know that it's a teaching hospital and you show up and people are just presuming that you are consenting to be treated by medical students. So this is, it seems like more specific consent is needed in these cases. If if it's heart surgery or something very risky, they should definitely make sure that you know that it's a teaching hospital. But less controversial is under cases of more routine procedures. Can presumed consent be sufficient in this case? So non-express consent in public health is going to be something like taking it as implicit. So it's like you take it as a if you show up to a clinic and they draw blood from you, presumed consent or non-express consent is that if it's easy for the clinic to just test you for HIV while there's an HIV outbreak ongoing, uh, it's an opt-in. It's an opt-out procedure, meaning that you have to opt out to not get tested, because if you don't know that you have HIV and you do have HIV, that could be a public health emergency. This is one of the reasons we said that autonomy might be limited in the prior slides. But you can still refuse the test if you, one, know that the test is going to take place, and then two, actually disagree with the test or don't want it for any reason. So this seems to be consistent with autonomy, unless you would like to opt out, but you didn't know that it was happening. That might be a case where your autonomy was limited. But again, this is in light of a public health emergency. So we feel that you can limit autonomy in those cases. We'll get to working consent in later lectures. One problem is that with autonomy is that patients' beliefs and choices change. So one is under dialysis. So a person might want to undergo dialysis when they need dialysis, but then after they get dialysis, they might change their mind. So uh, well, the case is actually person undergoes dialysis, feels fine because they have gotten dialysis, and then as the uh, filtration wears off, their blood accumulates byproducts. They start to get sick and feel bad. Uh, they would probably change their mind. They can be cases where they change their minds here if they say that they don't want to be put back on dialysis because they didn't because it was a terrible experience. But as the byproducts build up in their blood, they might now change their mind because they're in pain and mentally altered. So this is an obvious tension of autonomy where within the same person they change their mind, and the question is which informed consent should we accept? Should we accept when they want to not go back on treatment or when they do? Uh, and there isn't really, well, actually, it would be just nice for you to talk about this if you would like, um, the discussion post, uh, especially how this relates to Beauchamp and Childress's suggestion. Uh, and the way that Beauchamp and Childress take this is that when patients change their mind, they should be put back on dialysis to restore their clarity and then determine if their choice was autonomous. So this is going to require the kind of consequence of taking autonomy so seriously is that you can't respect a patient's choice, a current choice to refuse treatment when previously they've wanted to stay off treatment, but now, since they haven't had dialysis, they seem to be possibly altered, uh, especially in pain and vocally saying that they want dialysis. So Beauchamp and Childress are going to say that you should put them back on to make sure that they are consenting, giving their informed consent. Um, and this is might be bad because the patient might want have wanted to really die, but now they're being given dialysis again against their prior wishes, even though they changed their mind. And now, if they want to die, they have to go through the same process, the same painful, uncomfortable process of letting the dialysis wear off and the byproduct build up in the blood. So this is an interesting case. Maybe you disagree with Beauchamp and Childress. This would be a great thing to talk about in the discussion post. Make sure you reread that section and think about it. How taking a stance against autonomy would still get you all this stuff that we care about. On the one hand, with autonomy, patients choosing what they want, but also avoid doctors choosing what's right for patients all the time. So we're going to get into competency judgments in just a moment.